Good afternoon, everyone. iTech India welcomes all the participants for today's special NDLS session. Today's topic is ART treatment failure in adults and adolescents, and the speaker is Dr. S.K. Guha. Dr. Guha, sir, is the director of the School of Tropical Medicine, Kolkata. He is the chairperson of the Technical Resource Group on ART for adults of NACO. He is also the program director of the Center of Excellence, that is COE, in HIV care at SGM, Kolkata. He has received advanced training in antiretroviral treatment from the Prince Leopold Institute of Tropical Medicine, Belgium, and WHO training in second-line antiretroviral therapy in Bangkok, Thailand. Dr. Guha sir has published numerous articles on malaria, leishmaniasis, hepatitis, and HIV in national and international peer-reviewed journals. We welcome you, sir, for today's session. Please requesting participants to put their questions in the chat box. All the questions will be answered at the end of the session. Over to you, sir.
Good afternoon. Thank you for the introduction. So today we are going to discuss about the ART treatment failure in adults and adolescents, which we deal with in a day-to-day clinical practice at the ART center. Should we start with the pre-test?
Yes, sir. Please give us 2 minutes. Kiran sir, can we have the pre-test, please? Requesting all the participants to please attempt the pre-test. We have 5 questions in all. Scroll through the questions and click on the answer of your choice. We'll have 3 minutes for the pre-test. The first question is, which of the following is not a suspected treatment failure in patients on first-line ART for at least 6 months? And the options are new OIs or recurrence of clinical events after 6 months on ART, B, progressive decline in CD4 counts, C, iris, D, unsuppressed viral load. Second question is, which of the following is the correct order regarding the chronology of treatment failure? Is it immunological failure, virological failure, then clinical failure, or first virological failure, immunological failure, and then clinical failure? Third option, immunological failure, clinical failure, virological failure. Fourth option, clinical failure, virological failure, clinical failure. Third question, which of the following statements is true regarding timing of viral load test? For all PLHIV on first-line ART, plasma viral load testing should be done at 6 months and 12 months after ART initiation and thereafter biannually. For all PLHIV on second or third-line ART, plasma viral load testing should be done annually after initiation of second or third-line ART. The medical officer can request for additional plasma viral load test when deemed necessary for clinical management. Plasma viral load testing is recommended for all HIV positive pregnant women during every trimester, regardless of the duration of ART. Requesting all participants to please attempt the pre-poll. Fourth question, which of the following is true regarding the recommended regimen for failing DTG-based first-line ART? You have to mark all that apply. TDF plus 3TC plus ritonavir is recommended for failing AZT plus 3TC plus DTG. AZT plus 3TC plus ritonavir is recommended for failing TDF plus 3TC plus DTG if HB is more than or equal to 9. DTG BD plus ritonavir plus existing NRTI backbone is recommended for failing abacavir plus 3TC plus DTG if HB is less than 9. LPVR based regimen is recommended in case of pregnant women or HIV-2. The fifth question, which of the following ART regimen should be prescribed to PLHIV who had 2 NRTI plus PI as first line, failed on it, and are on INSTI-based second line? DRV BD plus DTG OD plus existing NRTI backbone. The second option, ABC plus 3TC plus DTG. Third option, ABC plus 3TC plus ATVR. Fourth option, DRV-RBD plus DTG-50BD plus existing NITI backbone. We'll wait for another minute, requesting everyone to please take the pre-poll. Kiran sir, we can end the e-poll now. So we can continue. So we can close the e-poll window.
So coming back to the session proper, so these are all the listed objectives for this particular session. One is an antiretroviral treatment failure definition. How do you diagnose it? And then talk about in the national program, the viral load testing strategy and the adherence support that is being given to pale HIV. And how do you manage our patients with first line ART failure as well as second line treatment failure? And drug-drug interactions with key antiretroviral drugs. These would be the major talking points in this particular presentation. So treatment failure, basically, when you talk about antiretroviral treatment failure, is essentially loss of antiviral efficacy against HIV replication, and that triggers increase in the HIV viral load with subsequent CD4 decline and ultimately clinical progression. And when there is a confirmed treatment failure, that it triggers the switch of change of the regimen from the first line to the second line or from the second line to the third line. It is usually suspected by immunological and or clinical indicators like WHO certain just stage 4 condition, but confirmation comes only through unsuppressed viral load. Unsuppressed viral load means it's a detectable viral load. And before identifying treatment failure, certain other factors like duration of ART, that should be at least 6 months on ART. And during this 6 months of ART, there can new OIs or IDs might happen, considering in the patient, if the patient's CD4 count is low, new OI might come up while the patient is on ART, during the first few months. And similarly, with if there is an immune recovery is robust, IDs might happen. And most importantly, treatment adherence has to be assessed properly before we suspect someone having treatment failure. So these are the definitions for virologic failure in the program condition of HIV-1 plasma viral load of more than 1,000 copies per milliliter at or after 6 months of continuous antiretroviral therapy with more than 95% treatment adherence. This is the keyword. And immunological failure, its CD4 count at 250 following clinical failure or a persistent CD4 count below 100 cells per cubic millimeter. The reason is that since we have moved into a routine virologic monitoring strategy in our program, the importance of immunological failure has gone down. We have only two criteria here. One is an persistent CD4 count below 100 cells, despite having ART regularly for 6 to 12 months is one. And another is following clinical failure if the CD4 declines at 250. But know that these parameters have got low sensitivity, specificity, as well as positive predictive value in identifying virologic failure. That's why the most important tool is to do the viral load. And clinical failure, which comes last. We know that with when the failure occurs, first is the virologic failure. After some time, there is immunologic failure, and then thereafter comes the clinical failure. And virologic failure may or may not be associated with emergence of antiretroviral drug resistance. It all depends on the nature of the antiretroviral drugs. Say, for example, if it is an NNRTI-based regimen, they usually fail with NNRTI mutation and associated M184V or lamivudine mutation. But if you are using our dolutegravir-based regimens like TLD or ALD or ZLD, whenever they fail, the dolutegravir or Insti second generation, when they fail, they are not associated with Insti mutations at the outset. However, if the patient is allowed to continue on the same failing ARV regimen for some time, the Insti mutations come up. Now, the viral load, plasma viral load is the recommended in the program as the preferred monitoring tool to assess ART response and identify and finally confirm treatment failure. So what are the timing of viral load tests? We all know about this, that PLHAV on first line ART, the testing is done after 6 months of initiation of ART, and then after 12 months, and thereafter once in a year or annually. But for patients who are already on second line or third line ART, the viral load testing is done every 6 months following initiation of second or third line ART. For all PLHAV who are transitioned, that means either substituted or switched, they should have a viral load test done at 6 months, 12 months, and then annually in patients on the first line, and every 6 months for patients who are already on second or third line. And for pregnant women, these are also all known to us, that a viral load test mandatorily has to be done between 32 to 36 weeks of pregnancy, regardless of the duration of ART. And the purpose here is to determine the risk of HIV transmission to the baby. And the chronology and the treatment failure. Why viral load is done? As I was talking about initially, when someone fails, you can see they fails and the viral load starts going up. This red line is showing a going up. CD4 is still high, but over a period of time, after some time, when the viral load is growing up, it's still remaining stationary and then starts gradually falling off. So if we go by immunologic parameters, we'll be identifying failure later, much later than virologic detection or virologic failure. And similarly, for the clinical status remains asymptomatic for a pretty long period of time, months to years, and thereafter it starts declining and they develop clinical condition like WHO stage 4 condition or certain severe stage 3 condition. So at that time, if we monitor our patients only by clinical parameters, we will be much late and the viral load would be pretty high. And on a regimen, when the viral load is multiplying, so there will be emergence of mutations that might uh, uh, challenge the development of an appropriate second line or third line ART regimen. That's why regular viral load testing should be done and has been incorporated in our national program to identify and confirm treatment failure. This is a busy slide. I think you have gone through it on many occasions. If you do, the algorithm says the conduct viral load test at the scheduled duration that we discussed in the previous slide. If the viral load is less than 1000 copies per milliliter, you continue the same ART regimen and routine monitoring testing that is being done. However, if the viral load copies is more than 1000 copies per milliliter, then one has to embark on enhanced adherence counseling for 3 continuous months, or EAC1. And who does it? A counselor, a counselor has to be dedicated who will be doing that counseling on 3 occasions under the supervision of the SMO or MO of the ART center. And after 3 months of enhanced adherence counseling, if it is less than 95%, then one has to go a second round of EAC or EAC2 by another counselor, by a different counselor under the direct supervision of the medical officer. After 6 months, that means 3 months in EAC1 and 3 months in EAC2, whatever may be the result of the adherence, after 6 months, even if it is less than 95%, we should go for a viral load testing. That's very important. We should not defer the viral load testing even if the patient's adherence doesn't improve. And based on the result of viral load, if it is less than 1000, continue with the same ART regimen and routine monitoring testing. And if it is more than 1000 copies, then e-referral to SACEP for further evaluation. However, if after the EAC1, if the adherence in the last 3 months is more than 95%, then conduct viral load testing. And similarly, if the green bar shows it is good one, if it is less than 1000 copies, you continue the same thing. And if it is more than 1000, you need to refer through the to the SACEP. Now, the small bullet points are very important. Like barriers of poor adherence should be identified and addressed during USC by the counselor under the supervision of the SMO or MO of the ART center. Involvement of MO and SMO to be ensured right from the beginning of ESC to look into the issues such as any clinical condition, concomitant medication, or drug interaction, and partial adherence. Counselors to ensure regular follow-up of such patients to ensure adherence on ART. PLHAV undergoing ESA2 should be rigorously followed up by the ART counselor through phone calls, and also seek support of the CSC either through phone calls or home visits if needed for follow-up of such cases to ensure treatment adherence. SACEP, the role of this SACEP is expected to look into and understand the reasons for poor adherence. What is the crux of this issue is the poor adherence. Understand the reasons for poor adherence of a particular PLHAV or any other clinical reasons for unsuppressed viral load to avoid unnecessary switch to a second or a third line. That is very important. And I think this is all. This is about the referrals, the mechanisms of how adherence EAC is being done at the ART center. There are 3 sessions, session 1, session 2, and session 3. These are all similar. In the session 1, one has to, the counselor has, in addition to the ART number, regimen, date of ART start, date of viral load, and the viral load result, due date of next viral load, etc. The name of the counselor, date, and ART adherence of the last 3 months you need to mention over here. And it's important that the assessing the patient's knowledge about the importance of ART adherence and the risk of poor adherence, viral load results, ART drug dose, number of pills, timing, etc. need to be assessed and all need to be captured in this format. And then also at the same time, the counselor has to identify the support system, like who is the caregiver or the relative or the spouse, etc. in the family or a buddy, and address and phone number of the caregiver all need to be recorded. And identify the most important thing, barriers. There are many listed conditions like forgetfulness, physical illness, social function, etc. And there can be something else also. So you need to, the counselor need to identify the barriers and suggest interventions like linking with certain social services and tools like, let's say for tools like phone calls, SMS, reminders, alarms, etc. that they need to do. And whatever the counselors do in this focused ESC counseling, they need to capture everything, and the counselor need to sign and also clearly write a adherence plan. She or he should act as the manager for that case. Similarly, for the second session also and third session, and if the viral load is more than 95%, then has to schedule a repeat viral load test after 3 months. Otherwise, goes for a second set of ESC through a different counselor. So this is auto-generated from the IMS, and all ART centers, the medical officers, they need to bring it up. This is auto-generated from IMS, the list of patients with unsuppressed viral load and SACEP referral summary. So you can find all those details have been the easy things that need to be captured here. And now, before you decide someone and confirm a treatment failure, one has to go through the treatment adherence, like a detailed assessment of adherence has to be done. The reason of non-adherence, as I am telling time and again, need to be explored, because ultimately the key to success lies on the fact whether the reasons for non-adherence can be accurately pointed out. Unless the reasons are identified, patient will find it difficult to adhere to the second line regimen. And of course, there can be drug-drug interactions. Patient might be taking some other drugs, non-prescription drugs, which the ART, SMO or MO may not be knowing about that, like Ayurvedic drug, or maybe taking TB treatment from somewhere, ART from the ART center. These things might also happen. And certain opportunistic infections or hibernating malignancies can also cause a steady decline of CD4, which might consider to be a case of immunologic failure. But then again, once you identify the OI like TB, you treat, and if there is an occult malignancy, you treat, then there will be a rise in CD4 count. So when viral load test report is available, line list of PLHIP with unsuppressed viral load should be generated on daily basis from the IMS. The list should be shared with counselor delivering services under the package C to telephonically follow up PLHIP with the unsuppressed VL and call them back to the ART center. Counselors should provide intensive support to improve the treatment adherence. A minimum of 3 sessions within a period of 15 days to 1 month as needed are recommended for step-up adherence counseling or EAC, and it is preferred that all counseling sessions are taken by the same counselor so that she or he acts as case manager to ensure consistency, continuity, and proper documentation of issue resolution. This session should be conducted when the patient visits the ART center to collect his or her pill pickup. Counselor should use the ready reckoner and step-up counseling form that Annexer 6 to facilitate the process. In case the patient is unable to come to the ART center and is on MMD, then 3 sessions of step-up counseling has to be done over telephone with proper documentation in step-up counseling form. That means that Annexer 6. During step-up counseling, HIV testing of spouse or partner and children should be facilitated or ensured. This is one more opportunity to identify undiagnosed pale HIV. Repeat viral load testing along with other lab tests should be done once treatment adherence is more than 95% for 3 consecutive months. And if the adherence is less than 95% during EAC 1, then EAC should be repeated by another counselor, EAC 2, and viral load to be done at the end of EAC 2, irrespective of the adherence that we discussed earlier. Though all efforts should be made to get to the appropriate baseline lab investigation done for switch. However, non-availability of those tests or results should not delay the referral. That's the bottom line. And people who are recommended to change the regimen by SACEP should be switched to new regimen as soon as possible after the SACEP recommendations are available. If the viral load count is 1,000 copies or more, e-referral to be made to SACEP within 2 days of receiving VL report without waiting for patient to come. This is important. You need to know, notice it, that it's the e-SACEP request should be mailed within 2 days after receiving the viral load result. And even if the patient is not there, SACEP has got a time of 1 week to respond, shall review the case on papers and share its recommendation to the ART center within 1 week through email. Simultaneously, the patient should be informed to come back to ART center for regimen switch as recommended by SACEP. Until the SACEP recommendation comes, the patient should continue on the same regimen. Now, what is SACEP? These are all aware of. SACEP is located at the Center of Excellence or the Pediatric Center of Excellence. The program director or the deputy program director of the Center of Excellence or PCOE are the members. So also one or more ART experts from the city, maybe from a different institution, and the joint director CHT or the regional coordinator of NACO or CST consultant at SACS, where SACEP is located. So they are also members. And pediatrician from the PCOE, if he is located in the same city, then he or she is also a member of that. And SACEP at ART Plus is headed by the nodal officer of the ART center and one more ART expert from the names provided by NACO or SACS, and designated representative from the SACS, DPM or DAPQ or regional coordinator. Pediatrician from the ART Plus center should be present there if the pediatric cases are discussed on a particular SACEP meeting. The SMO and MO from the ART center should attend the SACEP meeting by rotation. So when should a patient should be referred to the SACEP? We have already discussed about it. Patients with suspected ARV treatment failure, patients having moderate to severe antiretroviral adverse drug effects, which might need a substitution or of one or more antiretroviral drugs, drug-related complications or management of severe voice, that cannot be managed at that particular ART center level, that can be referred to as SACEP. And patients from the private sector on a regimen which is not the preferred regimen under NSAP, like TLD, can be referred to SACEP. Suppose someone is on Bictegravir, TAF, and emtricitabine-based regimen from the private sector. Now he or she wants to get the same medicine from the national program. The patient has to be enrolled under care at the ART center and refer the history to the SACEP. SACEP will be telling that the TLD is as good as Bictegravir-based regimen, so that regimen will be given. Now, there are two things regarding SACEP mechanism. We have learned a lot of things during the COVID pandemic, that e-SACEP happens, and there is a tele-SACEP. E-SACEP is basically patient's treatment details like history, viral load results, serial, and the latest CD4 counts, treatment adherence details over time, other relevant clinical details in the referral and reply form are mailed to the SACEP by the referring ART center. And the SACEP goes through this document. Based on that, in absence of the patient, they take a call and share their recommendation through email to the referring ART center, which is known as e-SACEP. And then there is tele-SACEP. Tele-SACEP is an post e-referral procedures. ART center and SACEP are virtually connected through a meeting like we are conducting today. ART center presents the case to the SACEP in presence, preferably in presence, or even in absence of the PLHAV for whom the case is being discussed. And the SACEP members might interact with the patient, might interact with the doctors, with the experts, other nodal officer of the ART center present, or the SMO or MO, and the counselors, and even talk to the PLHIV to ascertain the causes of failure, etc. And it gives its recommendation for further action through email. Benefits is basically to reduce turnaround time for SACEP review. So that's one thing. And it also reduces the need for multiple communications between ART centers and SACEP. So in one tele-SACEP meeting, everything gets decided. Provides an opportunity for mentoring and capacity building. This is important from the point of the ART center, so they can learn something new from the experts sitting at the SACEP. Can be used for patients' need in-person consultation, thereby avoiding the need for travel to travel to the SACEP, which may be located far away. Now, coming to the treatment regimens, once you diagnose the failure, let's go to this. Now, first line ART, we all know the antiretrovirals that is prescribed during when a treatment naive PLHAV, that's the first line. And second line, when the first line fails virologically, gets confirmed after at least 6 months of therapy, then the subsequent line is the second line ART. And similarly, third line is once the second line fails virologically and gets confirmed, thereafter the regimen that we use is known as third line ART. Now, we all know about these two definitions, substitution and switch, since our ART initial days. Substitution refers to replacements of antiretroviral drugs either due to adverse effects or to accommodate drug-drug interaction or program policy like phasing out, etc. But this does not mean actually any virologic failure or changes not being done due to treatment failure. Switch, on the other hand, it talks about the confirmed loss of antiviral efficacy to the existing antiretroviral regimen that requires entire change of the regimen. This is known as switch. Any substitution after 6 months should be preceded by viral load testing to confirm that the patient is virologically suppressed. This helps to understand whether a single drug substitution is enough, if the viral load is less than 1,000 copies, or whether the patient must be checked for treatment failure if the viral load is more than or greater than equal to 1,000 copies. Now, when someone fails some antiretroviral drugs, this slide actually captures the common mutations that takes place with different antiretroviral drugs, particularly the signature mutations. I am not going into the detail. I understand some of them like M184V, you know that this is selected by lamivudine as well as emtricitabine. The K65R is typically by tenofovir, also evacavir, etc. And the thymidine analogs like zidovudine, they also and thymidine analog mutations or TAMs are there. And there are broad nucleoside uh, 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 resistant mutants like Q151M complex and T69 insertional complex. Actually, if it is T69 insertional complex, all the the NRTIs, all the NRTIs and nucleotide analogs are uh, resistant. It's a T69 insertional. And for Q150M, all except tenofovir, all NRTIs become ineffective except tenofovir. Tenofovir still retains its activity against Q5011. I am not going into the detail of this slide, but this is someone is interested can go through on the further. Now, coming to the different regimens that are prescribed in our national program, how these regimens are decided. Like failing first-line regimen, the first column shows tenofovir or evacavir containing INSTI-based first-line regimen. That means it could be TLD or ALD or ZLD or TLD or ALD. Then if it is a failure, the second line has to be decided based on the hemoglobin level. If the hemoglobin is 9 gram per DL and above, then we can start ZL BD plus atazanavir ritonavir 300 100 once daily. ZL, as we know, it's available 300 and 150 milligram FDC. So one tablet BD plus one FDC of atazanavir 300 and ritonavir 100. Hemoglobin is less than 9 gram per DL, or if there is a past history of zidovudine induced anemia in the PLHIV, then we'll go with an in enhancing the dose of DTG 50 mg BD with ritonavir boosted atazanavir like in the previous condition 300 100 plus existing NRTI backbone. Suppose the patient was on TLD, and now the hemoglobin is less than 9. So where I can't use zidovudine, so we'll be using DTG with the dose will be enhanced from 50 OD to 50 BD, and atazanavir is a new class. The patient has not been exposed to PIs, so atazanavir ritonavir plus existing NRTI backbone of TL can be used. Similarly, if the patient fails with DTG-based regimen like ZLD, what happens? We move on to tenofovir lamivudine. If someone fails on zidovudine, it's a thymidine analog, then we need to go for a non-thymidine analog, tenofovir-based regimen, and a new class that is boosted PI, atazanavir ritonavir. So at present, our preferred second line, our first line is based on DTG. Our preferred second line is based on essentially on boosted atazanavir ritonavir. Similarly, continuing with that, and the other combinations like tenofovir and abacavir containing NNRTI based first regimen. Say for example, TLN or ALN or TLE or ALE based regimen. We had such patients in the past. Now these patients have been all shifted. So such patients, once again, since the major NRTI is a non-thymidine like tenofovir or abacavir, so we would prefer them to move on to zidovudine. So we need to check the hemoglobin. If the hemoglobin is good, 9 and above, then ZL plus dolutegravir. Here we are using dolutegravir as the second line because they have failed in NRTI like nevirapine or efavirenz therapy. So here we are using INSTI-based second line. DTG is the preferred one. Earlier on, where INSTI was the first line, we have chosen boosted PI like atazanavir, ritonavir as the best second line. So you need to remember all these small things. Hemoglobin, if it is less than 9, similar to the previous slide where you can't use zidovudine, you use atazanavir, ritonavir as well as dolutegravir OD. So one tablet of FDC of atazanavir, ritonavir 300, dolutegravir 50 mg OD plus existing NRTI backbone. There is an asterisk. I will talk about this asterisk at the end of the slide. Similarly, for boosted PI-based first-line ART, suppose someone was on atazanavir, ritonavir or lopinavir, ritonavir along with TL or AL. Similarly, the NRTI backbone, once again, we try to accommodate zidovudine, check hemoglobin. If it is 9 and above, move on to ZL plus dolutegravir because the person has not been exposed to INSTI. So dolutegravir is the preferred drug. If the hemoglobin is less than 9, then once again we use, the patient has now here, the patient has received either atazanavir, ritonavir or lopinavir, ritonavir as a first line. And now his hemoglobin is also less than 9. So we cannot use zidovudine. So use dolutegravir 50 mg OD and bring in the most potent PI, darunavir and ritonavir, 600 BD as well as ritonavir 100 mg BD, plus existing NRTI backbone. I think this is clear. And if the patient is on zidovudine-based regimen, whether the patient is on NNRTI or PI-based first-line ART, the preferred NRTI would be tenofovir lamivudine plus DTG. That means TLD, here it will be used as a second-line regimen. We use TLD as first line in a vast majority of our patients. Then again, TLD can be a second line regimen for certain patients like who have received either NNRTI or PI based regimen with ZL. If the patient has contraindicated to use tenofovir, then abacavir lamivudine can be used along with dolutegravir. Now this asterisk is there. Everywhere it has mentioned about existing NRTI backbone. Now, either you existing NRTI backbone, but if there are side effects or toxicities to existing NRTI backbones, you can also recycle the previously used NRTI backbones. Particularly two drugs, we use lamivudine in all. Two drugs have like tenofovir and lamivudine. Even if they develop their signature mutations like K65R for tenofovir and M184V or I for lamivudine, they retain some residual antiviral activity. So that's why they are actually that can be recycled. And you need to know, if you are not using an NRTI backbone, if the patient is hepatitis B co-infected patient, then whatever regimen you prescribe, you need to give either tenofovir lamivudine as a combined tablet 300 or you need to use entecavir 1 milligram once daily to suppress the HBV, hepatitis B, HBV DNA. Now, entecavir is now available through the National Viral Hepatitis Control Program. There are treatment centers as well as model treatment centers in each state. So, with networking with them, this is possible to get the medicines from them. Now, continuing with the further failures, there are patients who have received multiple NRTIs, both thymidines as well as non-thymidines during the first line itself. Now, what to do in such patients? Because the patient has received zidovudine or stabudine or received evacavir or tenofovir as first line, during first line, either due to change of side effects or stockouts or what are intolerance. So based on whether it's an NNRTI based first line or PI based first line, the second line would be, if it is an NNRTI based first line, it would be a boosted PI like atazanavir, ritonavir, OD, and since no NRTI options are left, then DTG has to be added. So it will be two new classes of drug, a boosted PI with an INSTI and definitely an existing NRTI backbone with the hope that the some residual activity of lamivudine or tenofovir. But if the patient has received PI based first line ART, then what do? We give them the second generation PI, darunavir. Suppose that someone has received atazanavir, ritonavir, or lopinavir, along with multiple NRTIs like ZL, TL, AL, SL, etc. in the first line itself, and they have failed on those regimens. So it will be essentially a boosted darunavir with higher dose 600, ritonavir 100 BD, and DTG 50 mg OD. And the existing NRTI backbone, if it is tolerated, can be continued. But if it is showing side effects, then you can recycle the older ones. The bullet points here that the PLHIV co-infected with TB and on rifampicin-based treatment, we know that they receives BID dose of DTG until 2 weeks after the completion of ATD, and subsequently OD dose is continued. So what we do, we give them a TLD, and after 12 hours, another DTG 50 mg tablet along with rifampicin-based ATD. And it should be continued even 2 weeks following cessation of TB therapy. Why? Because rifampicin induced this enzyme induction persists for at least 2 weeks. Any PLHIV who is co-infected with Hep B will receive tenofovir and lamivudine that we discussed, if not already receiving entecavir. If there is a contraindication to use tenofovir, then you need to add entecavir for that. And for those with HIV-2 or HIV-1 and 2 infection or pregnant women and toxicity to atazanavir, ritonavir, where atazanavir, ritonavir cannot be used, there atazanavir, ritonavir can be replaced with lopinavir, ritonavir 400 BID. Now there are certain scenarios have been given, first line, second line, and then third line. It might be showing a little busy for you. Now, just take the first one, PLHIV who has failed on 2 NRTI plus DTG as first line and now failing on PI based second line. So the failed first line was, let's say it could be ZL or TL or AL with DTG. When failed, and from the previous slides, says we have come to know you need to check for, if it is in tenofovir and evacavir, look to check for hemoglobin. And depending on the hemoglobin, if it is high, it can be on AZT, and patients who fail on AZT based regimen, they get TDF or evacavir. With TTC is common to all ARV regimens, plus either a boosted attenuated ritonavir or a lopinavir ritonavir. Or if the hemoglobin is low, then you get DTG BID because the patient is failing on DTG 50 OD. So DTG 50 BD plus a boosted attenuated ritonavir or boosted lopinavir ritonavir plus existing NRTI backbone, evacavir lamivudine or tenofovir lamivudine. Now, when this patient fails, so what would be our third line regimen? Essentially, the patient has received all drugs like DTG 50 mg BD, that's the maximum dose. He has received atazanavir, lopinavir. So we are only left with darunavir, ritonavir, 600, 100 BID, DTG 50 mg BD to be continued, plus existing NRTI backbone. Or if needed, some recycling of NRTI backbone is also allowed, checking the hepatitis B status. Or it could be DTG 50 mg BD, DRVR BD plus existing NRTI backbone in similar scenario. Either evacavir, tenofovir plus lamivudine. Now, the second scenario is someone who has failed on 2 NRTI and NNRTI at first line and now failing on PI based second line. So ZLN or TLN or SLN or ALN or ALE or ZLE or TLE or let's say ZLE, etc. This used to be our older regimens. When they failed, we moved them to PI-based regimen, atazanavir, ritonavir, or lopinavir, ritonavir, with change in between thymidine versus non-thymidine analogs. Now, when they fail, we move on to them DTG new class. So once daily DTG is good. And for darunavir, ritonavir, 600, 100 twice daily has to be used. And whatever the existing NRTI backbone has to be continued. But if the existing NRTI backbone is if intolerable or showing side effects, you can recycle previously used NRTI backbones. And the third scenario is PLHF who failed 2 NRTI and NNRTI as first line and now failing on INSTI-based, DTG-based second line. So first line is similar to the previous patient. And here, instead of boosted PI, we have used DTG as second line. So this was DTG OD. So it will be DTG BD, DRVR BD, and existing NRTI backbone. And continuing with such scenarios, PLHAV who failed on 2 NRTI plus PI as first line and next failing on INSTI-based second line. So PI-based failure, then moved on to DTG-based, INSTI-based second line and now failing on DTG also. So DTG dose will be BID and failed on atazanavir or lopinavir. So we'll bring in darunavir high dose, 600, 100 BD plus existing NRTI backbone. So this is not very tough. If you look into what the patient has failed, and that would be appropriate. This is the summation of the scenarios, first line, second line, and third line. So there is, above SACEP, there is the mechanism known as NACEP, National AIDS Clinical Expert Panel, is the mechanism to respond to the queries raised by SACEP of COE or ERT plus centers. Its functioning is coordinated by NACO through its consultations. So the COE or the ART plus center can pose questions or case summaries to NACEP, and then NACEP will give a coordinated reply to the centers. all patients, monitoring of patients on second line, these are all known to you. All patients on second line need to undergo viral load testing every 6 months. The viral load algorithm shall be followed based on the result that we have discussed. And as I said earlier, all second and third line every 6 months, first line 6 months, 12 months, and thereafter annually. Patients with unsuppressed viral load should undergo ESE. Once optimum adherence is achieved for 3 consecutive months, repeat viral load test should be done. But we need to remember that even after ESC2, even if the viral adherence doesn't improve above 95%, the viral load test has to be repeated. Now, good adherence. Workup of patients who are on second line failure. Refer all cases with suspected second line failure to COE or ART plus if adherence is good and there is no major Y. However, if there is poor adherence or major Y, then the center has to work with the patient, try to improve the adherence through ESC, closely monitor the patient, identify OI and treat it appropriately. If needed, CPT has to be started. If there is no improvement after 3 months, then the case should be referred to the COE or ART plus center. Prescription of third line regimen can be done by SACEP at COE and selected ART plus centers. Decision for initiation of third line ART shall be taken by the SACEP at COE or select ART plus centers as selected by NACO after e-review. After the SACEP has reviewed the patient and prescribed third line ART, initiation and follow-up dispensations would be done by the parent ART centers as done for second line. So patients don't require to be transferred out to the COE or to the ART plus centers. And so henceforth transfer out for initiation of third line ART is not required. Third line would be started at the primary ART center only after getting the prescription from the SACEP at COE or select ART plus centers. These are the monitoring tools. You all know that hemoglobin is done at the baseline and then 1 month, 3 months, 6 months, 12, 18, 24 months. LFT has to be done at baseline and at 3 months, 6 months, and thereafter every 6 months. Renal function test similarly 0, 3, 6, 12, 18, and 24 months. Fasting blood sugar 0, 12, 24 months. Fasting lipid profile 0, 12, 24 months. Viral load, as I said, 0, 6, 12, and then 18 and 24, because these are all patients who are on second or third line therapy. Viral load CD4 similarly. Now, just to clarify the CD4 testing after 6 months, CD4 testing should be done every 6 months till the CD4 reaches above 350 and the plasma viral load is less than 1000 copy. So it's not only the CD4 count, it's also you need to look into the viral load, whether it has been gone below the 1000 threshold, below the threshold of 1000. CD4 monitoring should be restarted for any patient if the patient has suppressed treatment failure, suspected treatment failure. That is virologic failure, viral load more than 1000. Maybe the CD4 is still holding high, but the viral load has failed, virologic failure. So once again, the CD4 monitoring should be continued or restarted. Or if the patient has undergone a switch in the regimen, the treating doctor can request for CD4 test or viral load test when deemed necessary for clinical management. So ART, SMO or MO have the power to order for a CD4 or a viral load test if clinically needed, if to identify whether to differentiate between a treatment failure or IDs. You can always order a CD4 test as well as a viral load test. When the patient is on the DTG based regimen, TB is the most common why amongst PLHIV. Although TB must be treated appropriately and on priority in the context of ART, drug-drug interactions need to be addressed. Any PLHIV co-infected with TB and rifampicin-based treatment receives BD dose of DTG until 2 weeks after completion of ATD and subsequently OD dose. This we have already discussed. And regimens containing PIs, here lies the challenge. Rifampicin alters the metabolism of PIs and reduces the effectiveness of standard doses. Rifabutin containing ATD in presence of PI containing ART if available without compromising the efficacy of ART or anti-TB treatment. Now, NSCP and NTAP both have recommended the substitution of rifampicin with rifabutin for the entire duration of anti-TB treatment. The dosage of rifabutin is reduced from usual 300 to 150 milligram once daily when it is administered with a boosted protease inhibitors like atazanavir ritonavir or lopinavir ritonavir or darunavir ritonavir. For PLHIV weighing more than 30 kg. But unfortunately, the rifabutin is very difficult to procure these days. So when rifabutin is prescribed, instead of usual FDC packs, individual anti-TB drugs, that mean loose drugs without rifampicin, must be dispensed to the patients as per weight band. Some of the common side effects of rifabutin we are well known. We need to remember two atypical side effects of rifabutin. One is an leukopenia, another is uveitis. So these two ART, MO and MO, you are all aware of rifamycin side effects and drug interactions, but remember for rifabutin, two things, leukopenia as well as uveitis. Now, the last bold and bullet is, since rifabutin is still not available, levofloxacin is to be used in place of rifampicin. So the TB treatment has to be altered when PI-based regimens in the second or third line. So this is something that we need to know, a little bit of challenge that we face, and we need to coordinate with the NTEP. And I'm not going into the detail of the second and third line drugs and their side. These are all, you are all aware of tenofovir, usually well tolerated, minor side effects, weakness, a little bit of flatulence, diarrhea. Initially, GI problem might happen, but people are more scared about bone and kidney toxicity, like a proximal tubulopathy with proteinuria, amino aciduria, phosphaturia, glycosuria, and resultant hypophosphatemia. And then the patient might have symptoms like myalgia, pain, weakness, bone pain, etc. And also it reduces the bone mineral density. So we are monitoring of routine urine and creatinine every 6 months is important for all patients who are on tenofovir. Dolutegravir is also, and regarding the treatment, if the patient is symptomatic, then probably it would be required to substitute tenofovir. We are using tenofovir disoproxil fumarate, which is a little more toxic on the kidney and bones, but it has favorable lipid profile. On the other hand, tenofovir alafenamide is also available, which has a lesser kidney and bone toxicity, but it raises the serum cholesterol, LDL cholesterol, as well as triglyceride. So, and calcium supplements might be required to treat certain patients, vitamin D, as well as in some patients there might be with an persistent severe osteoporosis with impending fracture risk, or alendronate or ivandronate, or all those drugs like need to be given in consultation with specialists. Dolutegravir we are using in so many patients, usually very much well tolerated. There are reports of insomnia, headache, very rare depression and suicidal ideation amongst patients who are having pre-existing psychiatric disorders. But we are more concerned about weight gain, particularly among female. And there are issues of asymptomatic transaminitis, which is now gradually being evolved. So that is a concern. So we need to monitor patients with LFT every 6 months. And these are the two, I think the slides have taken from 2021 when the neural tube defect issue was there. Now the SEPAMO study has clearly mentioned that there is no increased risk or signal of DTG induced neural tube defects in women who received DTG during the periconception period. So no further counseling is needed. In fact, DTG is the preferred for them as well, those who are planning pregnancy. Atajanavir we have used since long back. Apart from the specific atajanavir PI class specific like metabolic side effect like hyperglycemia, dyslipidemia, fat malabsorption, maldistribution like lipodystrophy and as well as lipohypertrophy, and increased bleeding episodes in hemophilia, etc. Atajanavir has got peculiar side effects of indirect hyperbilirubinemia without producing elevation of the liver enzymes. So there will be an indirect bilirubin will be high, indirect or unconjugated bilirubin will be high, eyes will be stained, so, and that might lead to cholelithiasis, pigment stone, or nephrolithiasis. However, these are like some sort of Gilbert's disease. If your patient has to be counseled, but if there is associated transaminitis, then definitely atajanavir ritonavir has to substitute it. Drug interactions with atajanavir cannot be used with um, certain drugs. Like with antacids, you need to give atajanavir at least 2 hours before or 2 hours after antacids or any buffered medication. Lopinavir boosted ritonavir use has gone down significantly, but then again, when GI side effects are common, abdominal pain, diarrhea, stool, and the metabolic side effects of PIs are more, since higher dose of 200 milligram of ritonavir is used as compared to atajanavir ritonavir, where use 100 milligram of ritonavir to boost atajanavir. Lamivudine, very well tolerated drug. I mean, not very issue. Darunavir it has got a sulfonamide moiety, so it might produce a skin rash. There are reports of Steven Johnson's or pain, etc. But then again, and it can also produce hepatotoxicity, GI intolerance. Otherwise, DRVR is well tolerated. But then again, all other things need to be monitored like blood glucose, lipid profile, etc. and lipodystrophy. Now, management of atajanavir, this is in case of hepatic insufficiency, dose adjustment is recommended. Child-Pugh score is utilized to assess the severity and prognosis of CLD or chronic liver disease and to identify patients who require transplant. Now, this should not be confused with the DILI. DILI is drug-induced liver injury. There are also people come across hepatic derangement, but that should not be confused with CLD or chronic liver disease. Child-Pugh score is employed only in case of CLD. The score is to be used only in those HIV-infected subjects who had concomitant CLD like chronic hepatitis B or C, alcoholic liver disease, or metabolic dysfunction associated liver disease or MAFLD and other chronic liver diseases. Atajanavir ritonavir can only be used with chronic liver disease, child park class A. For B and C, it's contraindicated. And there are tables and scores here. Child pack, these are all known to you based on two clinical criteria of presence or absence of encephalopathy and ascites, and three laboratory parameters like albumin, serum total bilirubin, or prothrombin time, or INR. Of these five attributes, and point 1, 2, and 3, it could be a range between 5 to 15. So these are all known, like no point, absence of encephalopathy 0.1, mild encephalopathy grade 1, grade 2.2, advanced encephalopathy grade 3, 4.3. Similarly, ascites absent, mild or easily controlled with diuretics grade 1 or 2.2, moderate or refractory despite diuretics 0.3, albumin more than 3.5, between 2.8 to etc., and prothrombin time and or INR. So you can have such things. Similarly, encephalopathy has also been graded: grade 1, grade 2, grade 3, and grade 4. These are all known to you. So the child park class A is between the point between the scale of 5 to 15. 5 to 6 is class A, 7 to 9 is class B, and anything above 9 is, that means 10 to 15 is class C. And class C are actually candidates for liver transplant. Now, these are important drug-drug interactions that are used to second and third line. DTG, we are all known. These are all known to us, that aluminum, magnesium, and calcium containing antacids, if you have to use along with dolutegravir, then dolutegravir has to be administered at least 2 hours before or at least 6 hours after antacids that contain polyvalent cations, because they reduce the DTG dolutegravir absorption, and the availability goes down significantly. Polyvalent cation supplements, in multivitamin and multiminerals, we often get magnesium, aluminum, iron, calcium, zinc, etc. Here the administered DTG and supplement that contains calcium or iron, either together with food or administered DTG at least 2 hours before or at least 6 hours after the supplement. Do not co-administer DTG during under fasting condition simultaneously with or 2 hours after supplements that contain calcium carbonate or iron. Rifampicin we have already discussed, so I am skipping the point on rifampicin. Carbamazepine once again is an inducer, reduces the concentration of DTG. So if it has to be used in combination, then DTG dose has to be enhanced from 50 milligram OD to 50 milligram twice daily. Metformin, on the other hand, is important. DTG increases the concentration of metformin. So the guidance is that you start with low dose of metformin, maybe 250 or 500 milligram once daily, and gradually up titrate the dose based on the glycemic control, in addition to other anti-diabetic agents. However, the dose should not exceed more than 1 gram per day. In normally the stated standard dose of metformin is up to 2 gram per day in divided doses. But in subjects who are on DTG based regimen, there the ceiling is 1 gram, because there can be hyperlactatemia and lactic acidosis. All protease inhibitors, they are already known to have plenty of drug-drug interactions, and for interaction you need to check for any new drug, and like the drugs like antihistamines like astimizole, cisapride, prokinetic, fluticasone, steroids, indinavir, lovastatin, simvastatin, midazolam, and tarfenadine, they all interact and avoid their use. Rifampicin, we have already discussed, we don't use, we use rifabutin at a lower dose, 150 milligram once daily with boosted PIs. Atorvastatin increased concentration is possible. However, atorvastatin can be used once again. Start with a low dose, 5 milligram per day, and then gradually titrate the dose, seeing the lipid profile levels. Pitavastatin is one drug which doesn't require dosage adjustment. So also rosuvastatin. The first generation statins like lovastatin and simvastatin, they are absolutely contraindicated with PIs. Atajanavir drug interaction is once again is there. Atajanavir requires acid for its acidic pH for absorption. So the bioavailability of atajanavir may get reduced when given with antacids. So use systemic antacids like aluminum or magnesium or calcium carbonate containing antacids. This systemic atajanavir ritonavir should be given at least 2 hours before or 2 hours after the antacids. H2 receptor antagonist, there are significant drug interaction. Administer atazanavir at least 2 hours before or 10 hours after the H2 receptor antagonist like famotidine or ranitidine. And the maximum dose of H2 receptor antagonist should not be equivalent dose of famotidine 40 milligram BID in ERT naive patients and 20 milligram BID in experienced patients. PPIs are not recommended in atajanavir ritonavir because of drug-drug interaction. If someone has to use, maximum dose can be, if it is PI non-experienced patients, unexperienced patients, one can use an maximum 20 milligram of omeprazole or its equivalent pantoprazole, lansoprazole, esomeprazole, etc. But then again, it has to be given at least 12 hours before. PPIs and the atazanavir ritonavir has to be separated at least by 12 hours. We talked about carbamazepine, so it's possible to substitute carbamazepine with other anti-convulsion drugs. Contraceptives, blood levels are also decreased with atazanavir ritonavir, so there might be contraceptive failure. That's why it said that if you have to use atazanavir with oral contraceptive, then that should contain at least 35 microgram of ethinyl estradiol. Buprenorphine exposure goes up, so also its active metabolite norbuprenorphine. So if the patient is on opioid substitution therapy along with atazanavir, look for sedation and other signs of symptoms of over medication. So patient might become drowsy. So a reduction in dose of buprenorphine would be required. Similarly, for methadone, opioid withdrawal is unlikely but may occur. Monitor for opioid withdrawal and increase methadone dose. Here, the reverse might happen. So the key points after this long session would be viral load has emerged as the preferred approach even in a public health program for monitoring PLHAV on ART over immunological and clinical monitoring. Early and correct identification of treatment failure is vital in preserving the second line options. This is very important. And clinical and CD4 monitoring essential for HIV-2 PLHAV since there is no validated and commercially available HIV-2 viral load assay. Importance of adherence to all lines, it's first line, second line, as well as the third line ART should be reiterated on every visit to the PLHAV for pill pickup. This is very important. So unless the patient becomes educated and understands the importance of taking all the pills on time regularly, it becomes difficult for them to adhere to the subsequent lines, second line or third line, where the pill burden goes up. Now our first line is only one pill a day, TLD, So if it fails, you need the number of pills goes up. It becomes twice daily regimen kind of thing. Second and third line regimens need to be initiated after SACEP review, but would be started at the referring ART center only. So I think I stop here, and
Thank you so much, sir. Sir, we have with us Dr. Rewari, sir.
oh, great.
Yes, sir, we would like to have your remarks too.
Yes, Dr. Rewari, your comments, please.
Dr. Guha, you have covered everything very well. I have nothing to add, but there are some good questions in the chat box which you may like to see and answer.
Oh, I can't see it. Oh, this is the chat box, no?
Yes, in the
Sir,
chat box.
I have
Three
put
questions
them.
are important. Yeah.
I have put them on in the slide.
If you can show me the questions, it becomes easier. What's
Yes,
your
so
opinion in bringing? There was a question, no?
Yeah. So I'll start with the first question.
Yeah. Start with the first question.
Yeah. If the patient is on ZLN, then his regimen is transitioned to TLD in accordance with the NACO guidelines. If this patient now goes into virological failure, what shall be his regimen in second line?
Minimize कर दो इसको. Sorry. Patient was on ZLN and this regimen transition to TLD in accordance with NACO guidelines. If this patient now goes to virologic failure, what shall be his regimen in second line? So the patient has received NNRTI in the first and been transitioned to TLD in accordance with NACO guidelines. So we need to look into whether when the transition was done, the viral load was suppressed or not. If the viral load was suppressed, then there was no issue. And then probably we can also use dolutegravir, and now the patient is failing on TLD based regimen. So the options would be D3G 50BD plus ATVR 300 100 OD plus the NRTI backbone of TL has to be maintained. If there is any issue with TL, then we can move on to GDL. That will be my answer.
Next question. A patient is on ALD. He is hepatitis B positive due to deranged KFT and so cannot be given tenofovir. In such cases, is it mandatory to give entecavir to such a case, even if his HBV viral load is within normal limits?
The problem is with monotherapy with lamivudine in HIV, HBV co-infection therapy is that by 2 years, there would be around 40% people will develop YMDD mutation against the lamivudine. And by 4 years, it will be around 90%. So monotherapy of lamivudine is not possible. Now here we cannot, because of deranged KFT, we are not using tenofovir disoproxil fumarate. TAF can still be used even if the creatinine clearance is up to 30. Beyond that, TAF cannot be used. But renal dose adjusted entecavir, I would prefer to add entecavir renal dose adjusted in this particular patient. Normally, in naive patient, the entecavir dose is 0.5 milligram once daily. And for patients who are LAM experienced and patients who are cirrhotic, the dose is actually entecavir 1 milligram or the higher dose. But we need to look into the creatinine clearance and then decide on the dose of entecavir. And as I said earlier, entecavir is now available free of cost to the ART center from the treatment center and model treatment center of the National Viral Hepatitis Control Program. And ANC PLHA case present just 2 weeks before delivery started on ART. Her ANC viral load done is TND. Will her infant be high risk or low risk? It will be low risk. It will be low risk. What is the guideline if the viral load is below 1000 but not TND? In the context of which one? If it is in our program, we say if the TND is basically it goes below the lower level of detection when any nucleic acid is not detected. So that level can be up to, let's say, 50. Some assays, it can be as low as 20 as also. Now, from the public health program, to take on a decision on viral load is 1,000. The WHO cutoff is 1,000. So anyone having a less than 1,000 is considered to be virally suppressed and is having a virologic control, and the same regimen need to be continued. But definitely TND is a much better target, but that may not be achievable for all patients, and particularly in public health program where options are limited in absence of genotypic drug resistance testing. I think we should stick with the guideline of 1,000 till WHO and NACO decides on that. What is your opinion about avoiding TDF for PLHB above 60 years? Because most of them will have decreased bone density and kidney issues. Very good question. But here in a public health program, if the patient has got definite CKD or borderline CKD or already having osteoporosis, is better to choose ALD rather than TLD. That is one, since staff is not available in the program. So Evacavir can be can be chosen over TDF in such scenario, since staff is not there. And your opinion, DEXA scan before starting PLHAV on TDF based regimen is not recommended in any guideline that one has to go perform a DEXA scan before starting ART. Patients are monitored if by the parameters of urine as well as blood parameters, and if the patient clinically seems to be suffering from bone pain, then only you can go for DEXA scan. DEXA scan does not give you an age. Many people will have low BMD before starting ART. So I would suggest not to go for DEXA scan, and it is not recommended in our program or WHO program. What should be the frequency of VL in patients who are regularly irregular with poor adherence at each visit and VL unsuppressed even after ESC2? I think it should be done after 6 months as is there, and probably you need to try to win over the battle of non-adherence. Like as I said, after ESC2, if the patient is the VL is unsuppressed, and adherence is then the major issue. And only problem is that we have got the one pill once daily regimen at first line. When you move from first line to second line, the pill burden, and the third line, the pill burden goes up. That we need to remember. So I think viral load can be done every 6 months. That's not an issue, but major issue would be how to deal with that particular patient. Patient in virologic failure in ESC1, if he defaults in first 2 visits itself, is there still a need for the third session of ESC1? Could he not start ESC2 session at his third visit? I think these are, I mean, you can do one thing is that the basic objective of ESC is to try and find out the cause of non-adherence and try to help the person so that she or he can improve her or his adherence. So if the patient defaults, we need to try and understand why does the patient defaults. That if needed, you need to think out of the box. Like we have in the presentation also, it was mentioned that one can go to the CSC can pay home visits, make phone calls, and these are all possibles, and try and there might be major issues and try to help them out. That's one issue. For PLHAV and palliative ART, after exhausting all therapeutic options due to virologic failure to third line, and just to come back to the previous question, this is not there, but probably sometime in the future, the long-acting injectable cabotegravir and injectable rilpivirine might be handy for such patients who are regularly irregular or having all sort of non-adherence, etc. So when maybe in the future those can be addressed to some extent by long-acting antiretrovirals of nanosuspensions of cabotegravir and rilpivirine. And the third question, PLHIV on palliative ART after exhausting all therapeutic options due to virologic failure to third line, which national ART regimen is the best, considering the fact HIV drug resistance can wane after a period of abstinence from ART? Yes, true. We have a number of drugs, and the third line regimen that we use, darunavir, ritonavir, 600, 100 BD, DTG, 50 BD, as well as on 1 TL, 300 TL tablet. I think that's a potent regimen that should be continued, even if the patient is failing the third line. That should be continued. Attempt should be made to identify the drug resistance, genotypic drug resistance, if it is feasible. And I agree that after a period of time, there will be archiving of mutations against drugs that are not in being used. Although there are now next generation sequencing for proviral DNA is now available commercially in the Western world, where the archived mutations can also be detected in such scenario. But then again, these are all theoretical discussions only. But always maintain our third line regimen is a very potent third line regimen. We need to continue with that even if the patient is failing virologically. Any other questions?
So we have a few in the chat box. Please give me a minute. Yeah. After initiation of TLD in PLHIV with HBV, at what point do you recommend checking HBV DNA titer to decide if entecavir needs to be added?
No. Where is the question?
So it's in the chat box.
What is the role of biologics? No.
No, you'll have to scroll a bit, sir.
Oh, sorry. After initiation of TLD in PLHIV with HBV, at what point do you recommend checking HBV DNA titer to decide if entecavir needs to be added? No, if the person is on TLD regularly by 6 months to 12 months, the HBV DNA will definitely get suppressed. We are yet to see someone who is on regular on tenofovir not getting suppressed in terms of HBV DNA. So I would suggest a repeat HBV DNA after 6 to 12 months. And entecavir, I hardly see any case where entecavir was required, barring patients who are only on lamivudine-based ARV regimen. I'm talking about HIV, HBV co-infected patients where tenofovir couldn't be used because of CKD and other issues. There we have added entecavir with good results. And in people who inject drugs on buprenorphine, OST and triple infection, what treatment chronology do you recommend? Should all treatments be initiated simultaneously or in a stepwise sequence? A very good question and practicable question as well. like OST has to be OST has to continue, and we need to start ART at the earliest. With definitely TLD would be the regimen that will required. And once the patient stabilizes, then the patients we can start sofosbuvir, daclatasvir if the patient doesn't have chronic liver disease. I mean, decompensated chronic liver disease. Otherwise, we can use sofosbuvir and velpatasvir as well. And dolutegravir goes pretty well, all those things. And buprenorphine, as I said, you need to look into all those issues. So I would suggest start treatment for ART that will cover both HIV and HBV, and then add on HCV. There is no harm to treat HCV. It's better to start for HCV. Otherwise, in HBV, HCV co-infected patient, if you treat only for HCV, there might be reactivation of HBV with a rebound of hepatitis B taking place. To prevent that, it's better to start HBV treatment, which will be along with the TLD regimen taken well care of, and then add soap dacla or soap valpatasvir. I think that answers the question. And maybe there is one, what is the role of, what is the role of biologics, interferon alpha? I'm not very much sure about that. BNAbs are now being tried. The broadly neutralizing antibodies are being tried. And then what's your opinion in bringing genotypic in NACO program? I think definitely, if you ask me, my personal opinion, it should be there, at least for limited number or select patients. And probably NACO, what I have heard, that NACO is moving in that direction very soon.
Thank you, sir. So do we take additional questions, or we could have a separate session again?
Whatever you like. I have time, but if they are still, are they still typing questions?
Oh, yeah, there's one in the chat box. How common is hepatotoxicity due to DTG?
It's not much. It's not much. We are currently carrying out a multicentric study in West Bengal in few ART centers to look into the incidence. I am not now in a position, I don't have the data, but if you see referrals, yes, there are referrals where asymptomatic transaminitis to the tune of grade 3 or grade 4 elevation of ALT or AST. But these are all patients. We analyze data of few patients, initial patients. A number of them has actually metabolic syndrome. That can also be a factor for rise in transaminitis of the ALT and AST. So whenever you come such patients, you also look for the metabolic dysfunction associated the MAFLD, fatty liver disease. Earlier on, we used to call them NAFLD, or non-alcoholic fatty liver disease. Then a number of these patients on DTG with asymptomatic transaminitis, they are also active user of alcohol. So it's difficult. So you need to, what is the impact of alcohol or insulin resistance or diabetes or hypertension or dyslipidemia, increased BMI, body weight, that we need to look into. But if you look into the literature, it's there. It's been mentioned of DTG can cause hepatotoxicity. But the incidence must be, I would say the number of patients being on DTG, I would say the incidence is low.
Next question. How about doing drug sensitivity test before starting third line ART?
Yes. Had this facility been with us in the program, definitely it would be recommended and it will be done. To identify active drugs is important, particularly amongst the NRTIs and certain classes of drugs where the second generation can be used. So, but then again, it's not there. But people are trying to get it done from some ICMR institutes or other institutes. They're into HIV drug resistance testing because it's costly. And then again, whatever being done in the private labs are also not very appropriate. Usually standard Sanger sequencing used to be done. Nowadays, the NGS platform is now available and increasingly being used. Advantage of using the NGS is that it can, in addition to the RT protease inst genes on the HIV genome, they can also look into the host cell proviral DNA, the integrated proviral DNA, and there they can identify the archived mutations. Suppose someone has received NNRTIs at the first line, nevirapine or efavirenz, not being used for the last 8-10 years. Now, still those mutations will be picked up by those NGS method, NGS genotypic drug resistance testing for proviral DNA. But I got this information in this year only in a meeting with NACO officials that they are planning to start it in 2 centers in the country. I'm not whether is someone from NACO is there in the meeting.
No, sir.
Or we can get this information from them later on. No issue. But definitely the question was definitely needed. In the Western world, they do it in a resource-rich setting. They do it upfront at baseline and after failure on each occasions. But these are absolutely costly and unavailable in the country as well.
Thank you, sir. We'll give mic access for another 5 minutes. Requesting participants try not to repeat the questions that have been covered. Kiran sir, can we please give mic access to everyone? Any questions? Participants are requested to please unmute and ask questions. So I don't think there are any questions. Thank you for the wonderful session. Thank you for your time. Thank you for your guidance. And this was a much needed session. Thank you, sir.
Thank you.
Poll or feedback?
Yeah. We'll run the feedback poll quickly, requesting participants not to leave the meeting. Please attempt the feedback poll and then you can leave.
Ma'am, feedback poll or post poll?
Post. Okay, you can have you can take the post poll first. Requesting participants to please wait for another 2 minutes. Yeah, please take the post test first.
कैमरा ऑफ कर दिया, ये भी ऑफ कर दो.
Requesting everyone to quickly attempt the post test and then we'll have the feedback form. The correct answers will be shared with the PPT. We'll wait for another minute. Kiran sir, we can end the e-poll and have the feedback poll now. Requesting all the participants to please fill in the feedback poll. There are 5 questions in all. Scroll through the questions and click on the answer of your choice. Please read the last question carefully. So thank you once again for giving us time for this session and facilitating this session. Thank you to all the participants for patient listening and active participation. Kiran sir, we can end the e-poll and we'll conclude the session now. Thank you.